things about iron that is unique is that iron tends to form salts in with with other nonpolar molecules, or sorry, other nonmetals that don't dissolve very well in water. Okay, an example would be iron oxide, which is rust. Okay, so we try to, whenever we carry iron around, we try to complex it with a protein that keeps it away from other anions, so that it doesn't end up becoming insoluble. Okay, so those things like hemosiderin and transferrin and stuff like that. Leukocytes, development of leukocytes is called leukopoiesis, right? They come from stem cells in bone marrow. The granulocytes mature in red marrow. The agranulocytes and the monocytes are released in the blood before they're fully mature. Growth factors and CSFs encourage production and maturation of white blood cells. Production increases in infection and in the presence of steroids and reduced bone marrow reserves. Okay. One of the things that we should note about this, right, is that the lymphocyte population has a very particular sequence of events, right? The B lymphocytes, M to the M, and monocytes, and granulocytes, all mature in bone marrow, right? And then are released into the blood. Okay. But the T lymphocytes are a little different. So they start in the bone marrow, in the red marrow, and then they move to the thymus and are then released. Okay. Hold on. I'll mute it. There we go. And are then released. Okay. So that's why they're called T lymphocytes. They mature in the thymus. The B lymphocytes mature in the bone marrow. B for bone marrow, T for thymus. Okay. All right. Development of platelets comes from megakaryocytes, right? The megakaryocyte undergoes mitosis, but not cytokinesis. So it gets a huge nucleus and it has these cytoplasmic extensions that extend into sinuses in the red marrow. And then those fragments that break off, they become platelets. Okay. Platelet levels are regulated by thrombopoietin and circulate for about 10 days before losing functional capacity. Senescent platelets are sequestered and destroyed in the spleen. So there's our spleen again, right? Hemostasis just means the cessation of bleeding, right? Requirements include the production of a platelet plug and then a fibrin clot, and then finally the dissolving of the fibrin clot after tissue repair has taken place underneath it, okay? It involves an extracellular cascade of clotting factors that are made by the liver and are always in the plasma, okay? As well as responses of the blood vessels, okay? The vasculature will constrict to reduce flow, and that promotes the clotting cascade as well as the platelets being trapped on damaged tissue and releasing factors that attract more platelets. And that's another example of a positive feedback loop, okay? So let's take a look at hemostasis.
Hi everyone. I want to start off by talking about Mary. Mary likes to play soccer, and she was at one of her games and she was running really fast. She scored a goal, and then she tripped and fell and scraped her knee. and then she started to bleed. Now, normally our bodies want to make sure that our blood, which it flows through our blood vessels, stays in our body. But if we have an injury that allows blood to leak out of the blood vessel and out of our body, we want to make sure we can stop that. And we do that through a process called hemostasis. And it's through hemostasis that we create this clot. And this clot allows the bleeding to stop. It stabilizes the injury in the blood vessel, and it gives the blood vessel time to heal. Now let's take a look at exactly what's going on in Mary's knee and exactly how we make this clot. So here we have a blood vessel, and in our blood vessel, we have our blood. In our blood, we have many different types of cells. One of the most important ones is our red blood cell that carries oxygen all over to all our tissues in our body. And in this blood vessel, we make sure that blood is flowing smoothly in one direction. Did you know that if we were to line up all of our blood vessels, the total length of our blood vessels would come out to about 150,000 kilometers, which is about 93,000 miles. This is the same distance as if we were to travel around the Earth a little bit less than 4 times. So you can see we have a lot of work, our blood vessels have a lot of work to do. And one of the cells that helps with this are the cells that line the inner wall of the blood vessel, the cells that communicate with the blood. These cells are called endothelial cells. And it's these cells that allow the blood to flow smoothly. And these are the cells that communicate with the blood whenever there's been an injury and hemostasis needs to begin. Now let's take a look at Mary's knee. She scraped her knee, so let's cause a break in her skin. Let's say this is her skin. And she also caused damage to the blood vessel underneath. So let me erase this. Let me cause some damage to the blood vessel. And so you can see blood that should be flowing in this direction now can come out of the blood vessel and out of the skin in this direction. We want to stop this. And the way we stop this is through hemostasis. There are 2 stages to hemostasis. The first stage is primary hemostasis. And this begins immediately after there's been an injury. And what happens is the endothelial cells at that site of injury begin to secrete proteins. And this sends signals to the blood that there's been an injury. And in our blood, we have platelets. These platelets are made in the bone marrow, just like red blood cells. And their purpose is to respond to injured blood vessels. And I drew them as squares, but they're actually about this small compared to a red blood cell. The reason I drew squares is I want to make a note of what they carry inside of them. They carry these sacs or granules that carry molecules and proteins that are necessary for hemostasis. So they store them and they're ready for use whenever needed. And so what happens is the endothelial cells secrete these proteins and send a signal to the platelets to come to that site of injury. And then a sequence of events happens with the platelets that I won't go into details here, but it allows the platelets to stick to that site of injury. They get activated, they change shape, they release what they have inside, and then they start clumping together and call more platelets and cause more platelets to clump there as well. And what we end up with is what we call a platelet plug. And this is the first step of stopping any bleeding. But this is still kind of weak, and we need to make this stronger. And that's where secondary hemostasis comes into play. In secondary hemostasis, we make this platelet plug stronger with a protein called fibrin. And what fibrin does is it lays over and links up on top of this platelet plug and makes it tighter and sturdier. It's like tying a knot. In order to prevent it from getting loose, you double knot it or triple knot it. And this is exactly what fibrin is doing. But fibrin doesn't flow in our blood as fibrin. It carries around an extra piece of protein. And when it has this extra piece of protein, it's called fibrinogen. So we need a way of getting fibrin from fibrinogen. And the way we do that is with this family of proteins called coagulation factors. And I'm drawing them all in one color, but there are several different types of coagulation factors. And the injured blood vessel will send signals to these coagulation factors to get activated. And once one gets activated, it will activate another, and activate another, and activate another. And then ultimately, that extra protein on fibrinogen will get cut off, and that will allow fibrin to link up on the platelet plug and make it stronger. This sequence of activation of coagulation factors is what we call the coagulation cascade. I won't go into the details here either, but it's just key to remember that in secondary hemostasis, we make this platelet plug stronger by getting fibrin from fibrinogen through the coagulation cascade. And it's with this fibrin mesh over the platelet plug that we create this clot. And it's this clot that stops bleeding, allows blood flow to continue through the blood vessel, and allows the blood vessel to heal.
So with platelet activation, we latch on to damaged tissue, we degranulate, we generate a platelet plug because these factors attract more platelets, okay? And in addition, we have vascular spasm, right? So the smooth muscle in the blood vessel will clamp down a bit, and that'll slow flow, and that concentrates clotting factors, and that promotes the clotting cascade, okay? And eventually what you're going to generate is a fibrin mesh that's going to trap other formed elements and allow basically to close the opening so that the bleeding will stop, and then set the stage for tissue repair underneath, right? There's a variety of pathways that produce a fibrin clot. The intrinsic pathway is activated when factor 12 comes into contact with subendothelial material exposed by injury, while the extrinsic is activated when tissue factor is released by damaged endothelial cells. And then there's a common pathway as well. So let's take a closer look at this.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
So for treatment, we give the missing clotting factor so that you can form a clot, okay? Once the clot has done its job, right, we don't need it anymore. In fact, we don't want it anymore. In clot retraction, the fibrin strands basically pull the wound together so that there's less possibility of, rupturing it and bleeding again. That's aided by platelets within the clot itself. But then after we've done tissue repair, fibrinolysis takes place, right? We actually dissolve the clot. Plasminogen and plasmin help us do this. Plasminogen is the precursor. It's converted to plasmin. And then the fibrin is broken down. Okay, you can see how this works here. Okay, TPA converts plasminogen to plasmin, breaks down the fibrin, and you've got new tissue underneath, so you don't have to worry about it at all, right? The vascular endothelium has a role in this as well with UPA and UPAR. Okay, and basically at that point we're done. This is critical, right? Because if the fibrin clot were to stay there and dislodge, then it could become an embolus. Okay. Blood cell counts increase above adult levels at birth because of the trauma of birth and cutting the umbilicus. Hypoxic intrauterine environment is going to stimulate erythropoietin production, resulting in polycythemia. Okay, so here we get the definition for polycythemia. Okay, polycythemia is an elevated red blood cell count. Okay, an elevated CRIT. Okay. Now, primary polycythemia is a disease process, and that usually indicates some problem with the red bone marrow, right? But secondary polycythemia is a normal response to high altitudes or low oxygen concentration, okay? Children tend to have more atypical lymphocytes as a result of viral infections as well, okay? What are atypical lymphocytes? Those that are not frequently seen, like basophils, and in some cases, lymphocytes that may have alterations in their structure. Okay, the erythrocyte lifespan is normal, but erythrocytes are replaced more slowly as we age because there's less tissue to do the job. Bottom line, okay. Possible causes include iron depletion, decreased serum iron, iron binding capacity, and intestinal iron absorption. Lymphocyte function decreases with age as well, and the humoral immune system is just less responsive. Okay, and that's true for all our body systems as we age, basically. Okay, there's just fewer cells to do the job, so the body system is less effective. Right. All right, let's bust for 20 and give me a chance to whip up some Q&A for you, and then we'll do a little bit of chapter 21, and then we'll only have a little bit of chapter 21 to do on Wednesday, and that'll leave you guys more time to deal with the quizzes and the second attempts and everything else. Okay, so let's do that now. That are out there. Okay. Examples include iron overload, all right, as a cause, and hereditary hemochromatosis. And I think we talked about the fact that this is one of those oddball diseases where we actually deal with it by bleeding you, right, by removing the excess iron so it doesn't build up to toxic levels. People with these conditions can actually set off metal detectors in airports if they don't properly treat it. You get so much iron in their body. Alterations of leukocyte function or quantitative disorders, increases or decrease in cell number, okay, bone marrow disorders or premature destruction of cells and response to an infectious microbe getting into the marrow as well. All right. Leukocytosis, anytime you see cytosis, that means there's more than the average number of those cells in your system, right? It's a normal response when you have an infection. You want more white blood cells. It's abnormal if you don't have an infection and can be an indication of something like leukemia. Okay. Leukopenia, penia means fewer than, right? Isn't normal and it isn't beneficial. A low white count predisposes the patient to infections. So an example of a condition that could produce leukopenia is AIDS. Okay. The helper T cell population is compromised by the HIV, right? And it takes it off task as a helper T cell, but it also turns it into a suicide pill because it expresses fast ligand. And anytime fast ligand and engages fast receptor, then what happens is that cell dies. Okay. And so that would result in leukopenia. Okay. Granulocytosis is a condition that occurs when there are too many granulocytes, which are part of our adaptive immunity, right? The neutrophils, the eosinophils, the basophils. They help the immune system fight off foreign invaders such as bacteria, viruses, fungi, parasites, and they can be caused by a lot of different conditions, including infection, autoimmunity, bone marrow disorder, and blood cell cancer. Okay. Neutrophilia is the first stage of an infection or inflammation. If needed for neutrophils increase beyond the supply, immature neutrophils get released into the blood. This premature release is detected in the manual white differential and is termed a shift to the left. When the population returns to normal, is termed a shift to the right. Okay. Neutropenia is just a reduction in the circulating neutrophils and can be caused by prolonged severe infection, decreased production, reduced survival, abnormal neutrophil distribution, and sequestration. So prolonged severe infection, you got to remember that the neutrophils generally are the first on the scene when there is an infection to deal with the bacteria, right? So if you've got like a chronic or a prolonged acute, then you're going to see a jacked neutrophil count. And what will happen as a result is that the neutrophils will do battle with the pathogen and their numbers will go down because remember, they're a primary component of pus. Okay. Decreased production, there could be something wrong with the marrow. Okay. And it could be inherited or it could be acquired, such as a viral infection or a cancer. Okay. Reduced survival, right? The neutrophil is defective for some reason. All right. And then abnormal neutrophil distribution and sequestration, right? Agranulocytosis can be the result of interference with hematopoiesis, immune mechanisms, the results of chemo and radiation therapy, and ionizing radiation. Okay. The idea with chemo and radiation is to kill rapidly developing cells. And the hope is that includes your cancer cells, right? But what can happen as a result of chemo and radiation is that you can compromise rapidly dividing tissue that's to your benefit. So this is why people on chemo and radiation lose their hair and lose a lot of their skin and their crit goes down and the lining of their gut sloughs off and they get very, very sick before they get better, if they do get better, right? And sometimes radiation chemo don't work, okay, especially in cancers that are slow growing, because their radiation and chemo are primarily designed to take out tissues and cells that are constantly in synthesis, because that's when they acquire the most damage from the radiation and the chemotherapeutics. Eosinophilia is an increase in circulating eosinophils. Hypersensitivity reactions trigger the release of eosinophilic chemotactic factors. of anaphylaxis from mast cells. We see an increase in allergic disorders, and that can be a cause. Remember that eosinophils, one of their jobs is to eat antigen antibody complexes. Okay. And then it can be increased in parasitic invasion because the eosinophil's job is to kill parasites like protozoa and helminths. Eosinopenia is a decrease in the circulating numbers of eosinophils, and it can be caused by migration of cells to inflammatory sites. Okay. Other causes include surgery, shock, trauma, burns, and mental distress. Note that all of these induce stress. Okay. And one of the things that happens with stress is the production of cortisol, and that is something that suppresses inflammation. And if we suppress inflammation, we can drop eosinophil counts. Basophils, remember, are the initiators of inflammation because they release histamine and heparin and cytokines, and that is going to bring on all of the processes that we associate with inflammation, right? In basophilia, we have an increase in basophils that circulate. This could be a response to inflammation and hypersensitivity, right? And is seen also in myeloproliferative disorders, bone marrow cancers, okay? Basopenia is a drop in circulating basophils and occurs in acute infections, in hyperthyroidism, and long-term steroid therapy. Now, why does long-term steroid therapy do this? When we're talking steroids here, we're usually talking corticosteroids, and we're talking in particular glucocorticoids. And cortisol and cortisone are known to suppress inflammation. Okay. Monocytopenia, all right, is a condition where the number of monocytes in the blood is lower than normal. Monocytes are the largest type of leukocyte, and in healthy adults, the reference interval for them in the peripheral blood is between 0.2 to 1 to the 10th per liter. Okay. Monocytopenia is diagnosed by a complete blood count, a CBC, along with a differential, and is defined as a reduction in blood monocyte count to 500 millicentiliters times, which works out to 0.5 times 10 per liter of blood. Okay, so you're dropping below a reference value. Monocytosis has a poor correlation with disease. It usually occurs with neutropenia in the later stages of infections, and the monocytes are needed to phagocytize organisms and debris, because remember that they develop into macrophages. Okay. Lymphocytosis, an increase in the number of lymphocytes in the blood. This can happen in acute viral infections, such as with Epstein-Barr. Lymphocytopenia, a drop in the number of circulating lymphocytes in the blood. This could be the result of acquired or inherited immune deficiency, drug destruction, viral destruction, radiation. Okay. A perfect example would be AIDS. All right. Infectious mono is an acute self-limiting infection of Epstein-Barr. It's transmitted by saliva through personal contact. B cells have an Epstein-Barr receptor. Other viral agents that resemble infectious mono include cytomegalovirus, hepatitis, flu, and HIV. Okay. The symptoms are fever, sore throat, swollen cervical lymph nodes, increased lymphocyte count, atypical lymphocytes. Complications include splenic rupture, which can cause death, and it's usually preceded by splenomegaly. Over 50% lymphocytes and at least 10% atypical lymphocytes is diagnostic. Monospot qualitative tests for heterophilic antibodies is one of the cardinal signs of infectious mono. And the treatment is symptomatic because the virus can remain latent in the body indefinitely, right? That's one of its strategies for avoiding destruction, is to integrate itself into host DNA and remain resident there for decades. Okay, it's the same strategy used by the herpes class of viruses, which are DNA viruses that can integrate. Okay, next thing we want to look at is leukemia.
Leukemia is a cancer that usually affects the white blood cells. White blood cells develop from stem cells in the bone marrow. Leukemia results when something goes wrong with the process of maturation from stem cell to white blood cell. Usually, there is a rearrangement of pieces of chromosomes that disturb the normal control of cell division. The affected cells multiply without restraint, becoming cancerous and ultimately occupying the bone marrow, replacing the cells that produce normal blood cells. These cancer cells may also invade other organs, including the liver, spleen, lymph nodes, kidneys, and brain. There are 4 major types of leukemia. Acute lymphocytic leukemia is a life-threatening disease in which the cells that normally develop into lymphocytes become cancerous and rapidly replace normal cells in the bone marrow. It most often affects children between the ages of 3 and 5, but can also affect adolescents and adults. Acute myeloid leukemia is a life-threatening disease in which myelocytes become cancerous and rapidly replace normal cells in the bone marrow. Exposure to large doses of radiation and use of some cancer chemotherapy drugs increase the likelihood of developing acute myeloid leukemia. Chronic lymphocytic leukemia is characterized by a large number of cancerous mature lymphocytes and enlarged lymph nodes. Chronic myelocytic leukemia is a disease in which a cell in the bone marrow becomes cancerous and produces a large number of abnormal granulocytes, a type of white blood cell. This disease may affect people of any age.
You all right? You look stressed out.
She is. Got a headache. I can feel it. I can feel the stress.
It's the leg
It's
shaking that's throwing me
radiating.
off.
I can see it from the corner of my
So what
eye.
we're talking about is white blood cell cancer, right? That's going to produce large numbers of hypofunctional white blood cells, right? And that doesn't really do us any good because it essentially interferes with the ability of your functional white blood cells to do their job, okay? Signs and symptoms: fatigue, bleeding, which include petechia and echomyosis. Petechia, remember, are ruptured capillaries. You can see them in the whites of the eyes and under the skin, okay, and under the nails. Fever, weight loss, bone pain, high uric acid levels, liver, spleen, and lymph node enlargement, infections, neurologic manifestations. The clinical terms for enlarged liver, that's hepatomegalia, okay, and splenomegalia for the spleen, okay. Acute leukemias, like the name implies, come on quickly, right? Acute lymphocytic leukemia, too many lymphoblasts, occurs often in children. Acute myelogenous leukemia, too many myeloblasts, it's a common adult leukemia, and is manifested by bone marrow depression. Signs and symptoms include fever, anorexia, and neurological problems. How do we deal with this? There's drugs out there that can be used, okay, that are effective against certain leukemias. The last ditch effort to treat leukemia is bone marrow replacement. So what we do is we do whole body radiation. We kill all your bone marrow, your red marrow, and your axial skeleton, and in your proximal femur and your humerus. And then we repopulate it with compatible donor marrow. And normally that'll fix the problem if the donor marrow takes, okay? The reason this is dangerous is because if this fails, you're going to die, all right? Because you won't have a source of blood. So we try everything before we go to bone marrow replacement. Chronic leukemias include chronic myelogenous leukemia with too many blood cells made in the marrow, chronic lymphocytic leukemia, too many immature lymphocytes, the most common adult leukemia. It's a slow progression and it's characterized by lymphadenopathy. You can see it here, right? Enlarged lymph nodes that get palpable and tender, right? Local lymphadenopathy is drainage of an inflammatory lesion located near the enlarged node. General lymphadenopathy occurs in the presence of malignant or non-malignant disease. So what you're talking about here is that the nodes that are dealing with the drainage, all right, are going to be the ones that are working the hardest and the ones that swell up and hurt. Okay. So this is why, for instance, if you have, say, an abscessed tooth, you may get an enlarged lymph node in your neck. Okay. Or if you have a lung infection, you may get enlarged lymph nodes in the axillary region, in the armpit. Okay. What you're seeing here is just generalized lymphadenopathy in the panel to the right. Okay. Let's take a look at lymphoma.
Not a lot is known about what causes Hodgkin lymphoma. In some cases, the virus that causes glandular fever, the Epstein-Barr virus, is found in tumor tissue. This virus could be involved in the disease process in some way, but most people who have the Epstein-Barr virus don't go on to develop Hodgkin lymphoma. So although there's some connection, it isn't clearly identifiable what that connection is. A lot more work needs to be done to understand the causes of Hodgkin lymphoma. It's important to stress that Hodgkin lymphoma is not an infectious disease. You can't catch it from somebody else. And when you have Hodgkin lymphoma, you can't pass it on to anyone else either. Like all cancers, it's not contagious. Many people with Hodgkin lymphoma go to see their doctor concerned by the appearance of painless lumps in their neck or under their arms. Other people with this disease feel quite well, but a wide range of other symptoms can occur, including fevers, night sweats, itching, weight loss, pain after swallowing alcohol, and tiredness. Of course, these symptoms can also occur with many other conditions. In Hodgkin lymphoma, some or all of these symptoms can occur without any obvious lymph node enlargement, and under these circumstances, diagnosis can be very difficult. A definite diagnosis of Hodgkin lymphoma is made following a test called a biopsy. This means taking a specimen from the lump or sometimes taking out a whole lymph node and looking at it under a microscope. This is done by a pathologist. Sometimes a group of expert pathologists will look at the sample to help decide what type of lymphoma it is. The exact type of lymphoma is very important in planning the best treatment. In Hodgkin lymphoma, the cancer cells are called Reed-Sternberg cells and have a characteristic appearance under the microscope. However, not all Hodgkin lymphoma biopsies look the same, and several types are recognized. Indeed, it is not always possible to say whether a lymphoma is Hodgkin lymphoma or non-Hodgkin's lymphoma. There is a grey zone where a clear-cut diagnosis is very difficult.
When I was diagnosed with Hodgkin's lymphoma, it was back in 2002. If I look back at the history of how I actually sort of found out that I was diagnosed, it was a case of, if you go back even as far as sort of December 2001, I felt myself getting very tired very quickly and not being able to do what I could do. I used to be quite fit, used to work for a fitness company and do some personal training, and my role within the company was quite demanding because I was in a quite high-pitched sales role. And I just found an 8-hour day at work suddenly became a 9-hour day, and then suddenly became a 10-hour day. And it just took longer and longer to do the things I'd normally do. It came to about February. I thought, actually, I need to go and get myself checked out, and went to see sort of a GP, and they said, done normal checks and said it might be something like glandular fever. So I've gone through to see them. They've given me some antibiotics, come back in 4 weeks' time, sort of thing. Done the antibiotics, went back in 4 weeks' time, and nothing had changed, still feeling the same. Then it was a case of, okay, I think alarm bells are starting to ring. So I was then referred to the hospital. It was a case of going through to see the specialists there, which they undertook some tests, some blood tests. They decided that they actually wanted to have a look at the lump which was in my neck. They'd done a biopsy. From that biopsy, there was the results from that, obviously further blood tests, scans, chest x-rays, of which it was then diagnosed that yes, this is Hodgkin's lymphoma.
So I was first diagnosed with Hodgkin lymphoma at Wigan Infirmary in 1999. I'd gone to the doctors with a niggling back, just a little niggling pain in my back, and I felt very tired, and they told me I was very anemic. So they were doing tests on me in hospital, and then after about 4 days, they sent me for a routine chest X-ray, and then that's when they found the main mass in my chest. And they said pretty quickly that they thought it was Hodgkin lymphoma, that I'd need further tests. I needed a scan, a full body scan, and then they also did a biopsy in my neck.
Staging means finding out which areas of the body are involved in the disease. Staging involves a very careful clinical examination and a range of blood tests, x-rays and scans. A bone marrow test is also sometimes needed. 4 stages of Hodgkin lymphoma are recognized. Stage 1, where the disease is limited to one group of lymph nodes. Stage 2, where disease is limited to 2 or more groups of lymph nodes on the same side of the diaphragm, that is, in the upper or lower body, but not both. Stage 3 involves lymph nodes on both sides of the diaphragm. And in stage 4, the disease is spread out of the lymphatic system. Each stage is also given the suffix A or B, where B indicates the presence of significant fevers, night sweats, or weight loss, and A denotes the absence of these symptoms.
So you can see here some of the classic signs and symptoms: cervical lymph node enlargement, and you can see the locations in the other insert where there are common sites in red for Hodgkin's lymphoma to set up. Okay. Notice that the lymph nodes are primarily in the cervical, the axillary, and the inguinal region, and quite a few also in the chest and the abdomen. And that's because those are all sites that have ports of entry, or sites that are near organ systems that have ports of entry. Okay. Let's look at non-Hodgkin.
The lymphatic system is part of the body's immune system, which is responsible for keeping the body free of disease. The lymph nodes throughout the body are connected by a network of lymph vessels. Lymph is a fluid found within the lymphatic system that contains lymphocytes, infection-fighting white blood cells. In the nodes, bacteria and other dangerous substances are filtered from lymph before fluids are returned to the bloodstream. 2 types of lymphocytes are B cells and T cells. B cells help the immune system by producing antibodies to eliminate infection. T cells are important in regulating the immune system and in fighting infections. Non-Hodgkin's lymphoma is a cancer that develops in the lymphocytes. The primary types of non-Hodgkin's lymphoma are classified according to the lymphocyte that is affected: B-cell lymphoma, which is most common, and T-cell lymphoma. Cancer of the lymphocytes interferes with the normal immune process, leaving the body unable to fight infections and allowing bacteria, viruses, and other disease-causing agents to overwhelm the body. Simple infectious agents encountered on an everyday basis that normally would not even be noticed are now debilitating and, in some cases, life-threatening. Because the lymphocytes circulate throughout the lymph system, the cancer can spread to other parts of the body, resulting in other organ function failure. Symptoms of non-Hodgkin's lymphoma include swollen lymph nodes, fever, night sweats, chills, fatigue, unexplained weight loss, and facial swelling. Non-Hodgkin's lymphomas are described as either being indolent, slow growing with few symptoms, or as aggressive, growing and spreading quickly with severe symptoms. Treatment depends on the stage and type of lymphoma. Standard therapy includes radiation and chemotherapy. Experimental therapies include hormonal therapy and high-dose chemotherapy with stem cell transplant. Most patients with non-Hodgkin's lymphoma can benefit from some type of treatment. Complete cure is possible for many patients. For others, treatment can provide relief of symptoms and extend life expectancy.
Burkitt lymphoma is a rare aggressive type of non-Hodgkin lymphoma that hits B lymphocytes in the lymphatic system. It's named after Dennis Parsons Burkitt, first described the disease in 1958 in equatorial Africa. Burkitt lymphoma is a fast-growing and usually affects children with less frequent occurrence in younger adults. It's relatively rare in Western countries, but it's very common in Central Africa. Okay? Burkitt lymphoma are fast-growing tumors. They're often found in the jaw and the facial bones. All endemic Burkitt lymphomas are latently infected with Epstein-Barr. Okay? Lymphoblastic lymphoma is a clone of immature T cells that become malignant in the thymus, a painless lymphadenopathy of the neck, and possibly in the chest, where we call that a mediastinal mass. Remember, the mediastinum is the cavity between the pleural cavities, which contains the pericardium. Right? Next, let's look at multiple myeloma.
Hello, I'm Rafael Fonseca, a hematologist at the Mayo Clinic in Arizona. I'm here to talk to you today about multiple myeloma. Multiple myeloma is a cancer that arises from the bone marrow, and it's a cancer that arises from the malignant transformation of cells that are called the plasma cells. You will see people refer interchangeably to plasma cells as the myeloma cells, but under normal circumstances, plasma cells would be cells that help us fight off infection. These are cells that produce antibodies. These antibodies chemically are proteins, and therefore you will see the terms being used interchangeably. And we will talk about proteins, we'll talk about immunoglobulins, but we're all talking about the same thing. This is a substance that is produced by the cells. Myeloma, it's not that uncommon. It's 3 times as common as leukemia. And there's nearly 20,000 people diagnosed with myeloma every year in the United States. Myeloma is a condition that primarily starts from the bone marrow, and we don't see a lot of cells in the circulation like you might see in leukemia. So the blood counts are, for the most part, normal, with the exception that they will show anemia. And the reason you have anemia, that's a low red cell count or a low hemoglobin, is because the myeloma cells living inside the bones and in the bone marrow will take up the normal space that is used for the production of red cells. And that's why one of the symptoms that patients will have is anemia. Other features of myeloma include damage and erosion into the bones, what we call myeloma bone disease. Patients will sometimes have what we call lytic lesions or punched out lesions, and that is loss of bone structure as a consequence of the myeloma growth. Sometimes there's so much erosion, and as you know, the bones contain a lot of calcium, that a patient will have very high calcium levels, what we call hypercalcemia. Lastly, the proteins, the small fragment of the proteins can be filtered down through the kidneys, and occasionally this will be very toxic to the kidney. So a subset of myeloma patients will present with either renal insufficiency or frank renal failure. So those 4 things define the complications of what we call myeloma, and that is often referred to by the acronym of CRAB. C for calcium, R for renal abnormalities, A for anemia, and B for bone disease. While myeloma remains, for the most part, an incurable disease, our ability to treat the disease is much better than what it was 5 and 10 years ago. For many patients, myeloma has become a chronic condition, and the number of therapies that are available are sometimes 5, 6, or even 7 lines of therapy for patients diagnosed with this condition. The treatment of myeloma has classically incorporated the use of high-dose chemotherapy with stem cell support, what we call also bone marrow transplant. For the most part, this is transplant done with your own bone marrow, self-transplant, or what is referred to as autologous transplant. But we also are introducing more and more some of the novel agents that are available for the treatment of this disease. There's 2 broad group of agents that we're using for the treatment of myeloma. Number 1 are called proteasome inhibitors. I know that's a mouthful. The prototype for this is bortezomib, also known as Velcade. This is an injectable medication, and it's something that has been approved because of its ability to control the disease. The other group of agents includes drugs such as thalidomide, lenalidomide, and then now most recently pomalidomide. These are given in the pill form, and this is another way in which myeloma can be treated. How to select the agents, when to introduce them, when to combine them, it is all part of a complex decision process that is best made with your provider at the time of the consultation. We believe it's crucial to be very engaged as a patient, to gather as much information as you can, and to talk to your physician so that you can decide on the best long-term plan for the management of multiple myeloma. Lastly, I'd like to make a brief mention of the use of prognostic markers and genetic tools for this planning for the myeloma therapy. As you will hear, both in the literature, through some of the patient support groups and the communications that are available for patients, that more and more we're moving into this area of personalized medicine for the disease for multiple myeloma. We will oftentimes require that we do testing for genetic factors, and we bring that information forward as we select what therapies and at what time to use them for a given patient with myeloma. Thank you very much.
So you can see it here, right? Multiple myeloma, also called plasma cell myeloma or myeloma, is a cancer that occurs when the plasma cells, which are a type of white blood cell, grow too much and crowd out other cells in the bone marrow. This causes the abnormal production of an antibody called M protein, right? What you're looking at on the right is a rentnogram of the femur showing extensive bone destruction caused by the tumor. Note the absence of reactive bone formation. In panel B, gross specimen from the same individual, myeloblastomas, pronounce this correctly, myelomatous secretions appear in dark granular sections, okay? So these malignant plasma cells infiltrate the marrow, aggregate into tumor masses, okay? They make that diagnostic antibody, okay? And other markers include Bence-Jones protein. We see hypercalcemia, renal failure, and we see bone lesions as well. Okay. Alterations of splenic function include splenomegaly, that's enlarged spleen, hypersplenism, congestive splenomegaly, and infiltrative splenomegaly. Okay, congestive splenomegaly means that the blood flow is blocked somehow. Okay, through the spleen, whose job it is normally to recycle worn out red blood cells and also to remove pathogens from the blood. Infiltrative splenomegaly means that we have something blocking the movement of the material through the sinuses that are in the spleen. Okay, immune complexes could be an example, right? Next thing we want to look at is thrombocytopenia.
Hello friends, I am Dr. Pritesh Junagade, hematologist and oncologist practicing in Nashik and Mumbai. I have been trained in hematology and oncology for 7 years, while my stay in UK, London. Today I am here to tell you about thrombocytopenia, meaning low platelet count, which is very common in our society. There are two reasons why I am discussing or sharing my views about thrombocytopenia. One, there are many misconceptions about low platelet count, and many of the population, especially in our country, are unnecessarily worried about low platelet count. Number two, I also want to give a message that low platelet count can be a serious disorder as well. So you can't just neglect a low platelet count of thrombocytopenia. So let's see in next 5 to 6 minutes how we can understand low platelets of thrombocytopenia and take steps to diagnose and treat this condition efficiently. What are platelets? Platelets is a type of cell in our body, in our blood, which is formed in your bone marrow. They come out into your bloodstream, they stay alive for 7 days. They are tiny structures. Their function is to prevent bleeding, or they promote clotting, and the other way around. So if you have a small cut while shaving or a small injury, platelets are the structures which go to the site of injury and they help in forming a blood clot. So obviously, if your platelets are low, which is called thrombocytopenia in the medical terminology, you will be prone for easy bruising or easy bleeding. That's how many of the patients of thrombocytopenia or low platelets present to a doctor. How did you come to know that your platelets are low? Without doing a test, of course, is number one, if you start getting bruises or blackish, bluish areas on your skin or tiny pinhead like red dots on your feet, or some patients have easy bruising, bleeding from the gums, bleeding from the nose. And these are the common presentations of low platelet count in a given patient. So what are the common causes? Why your platelet count goes low in certain patients? Well, again, there are many causes. The commonest are any infection, especially any viral infection which you all get, can lead to a low platelet count. Many of these, 90% of these people, it is not low enough to cause any problems. But with the new advanced tests which are available in our society today, we easily diagnose low platelet count. This was not the case 20 years ago. People used to get viral infection 20 years ago. We also had low platelet, but we didn't have a machine to count them. Now we've got a machine, so we come to know how common this condition is. So 90% of patients who've got viral infections, sometime or the other, the platelets are low. In most of these patients, you don't need any special treatment for low platelet. In 10 to 20% of these patients, when the platelets are very, very low, you need to be admitted in the hospital. And in certain patients, we need to give platelets from outside, which is called a platelet transfusion. So this is viral infection causing thrombocytopenia. The doctor will easily come to know and can suggest you treatment for low platelet count for the same. The next common cause is drugs or any medications which you are taking or some other medical needs. Many drugs can lead to thrombocytopenia, and this should be kept in mind. Young children given routine vaccinations can lead to thrombocytopenia or low platelet count. Again, poor diet, especially vitamin B12 deficiency, which is a source, which is an important source of vitamin, or which is important for platelet production as well, can lead to low platelet count. Again, you should remember certain hematological diseases. There could be serious diseases like aplastic anemia, blood cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma. All these conditions can also cause low platelet count. There are certain other rare diseases in the bone marrow which can lead to low platelet count. Also, if you've got repeated infections, an organ in your body which is called spleen enlarges, and your platelets might be destroyed in that organ, which is there in the left side of your body. That can also lead to thrombocytopenia. So these are the common causes of thrombocytopenia or low platelet count in our society today. Next, few lines about the treatment. How do we treat patients? As I earlier told you about viral infections, patients can be treated on the basis of their low platelet. If it is very low, we need to be admitted. Only 10 to 20% of patients need to be admitted with low platelet count. The rest of the patients can easily manage by outpatient basis, meaning they need not be admitted. Few of the patients who have really bleeding from gums or nose, who are big bruising, we need to give platelets from outside, from a donor, from a blood bank. That is called platelet transfusion. Again, we need to do certain special tests, which is called a bone marrow test, to find out whether platelets are being formed in the bone marrow. If they are not formed, there are certain diseases, other diseases, serious diseases we need to treat, and we'll treat them accordingly and should be treated by a hematologist. Well, after all this, low platelet count is treatable today. You don't need to panic. Always when the platelet counts are low, you should ask the doctor why your platelet count is low, and you should get a satisfactory answer from him. Again, spread this message that low platelet count is common, but you don't need to worry, you don't need to be panicked just because your platelets are low. Thank you for patient hearing, and if you need any further information, please do visit our website, which is there on your screen now. Thank you.
Heparin-induced thrombocytopenia. IgG antibodies target heparin platelet factor 4 complex. It typically causes a 50% drop in platelet count. Okay. Idiopathic thrombocytopenic purpura is a chronic form that has IgG autoantibodies that target platelet glycoproteins. Antibody-coated platelets are sequestered and removed from circulation. Basically, your own immune system destroys them. The acute form of ITP, it often develops after a viral infection, is one of the most common childhood bleeding disorders. What do we see? We see petechia and purpura. We see progression to major hemorrhage. Remember that petechia are ruptured capillaries that you can see in the sclera of the eye and under the fingernails and under the skin. Purpura is basically internal bleeding. Okay. Thrombotic thrombocytopenic purpura, or TTP, is a thrombotic microangiopathy. The platelets aggregate and they form microthrombi and cause blockage of arterioles and capillaries. There's different types: chronic relapsing TTP and acute idiopathic TTP. Remember that the term idiopathic means cause unknown. Okay. Essential thrombocytopenia. Essential thrombocythemia or thrombocytosis is characterized by a platelet count over 400,000 per cubic millimeter. Okay, it's a myeloproliferative disorder of platelet precursor cells. Megakaryocytes in the bone marrow are produced in excess. Microvasculature thrombosis or hemorrhage will occur. Okay, now you might wonder, okay, you're making all these extra platelets, why are you hemorrhaging? Okay, it's the same reason that you hemorrhage in DIVC, okay, disseminated intravascular coagulation. You're titrating out your clotting factors in the plasma. And so when you have an actual injury, you're going to bleed, all right, excessively, because it's going to take longer for the fibrin clot to set up. Other changes in platelet function: qualitative alterations demonstrate an increased bleeding time in the presence of a normal platelet count. And we see petechia, purpura, mucosal gingival bleeding, that's bleeding in the gums. And then disorders can either be inherited or you can acquire them, right? One example is vitamin K deficiency, which is critical for synthesis and regulation of prothrombin, the procoagulant factors, which are 7, 11, and 10, and proteins C and S, which are anticoagulants, right? Liver disease causes a broad range of hemostasis disorders, defects in coagulation, fibrinolysis, and platelet number and function, not to mention the fact that you have a drop in most clotting factors because they're manufactured by the liver, as well as a decrease in albumin production and a decrease in complement production, which makes you more likely to succumb to infection. Okay, let's take a look at DIVC.
Hey, this is Dr. K from iMedical School, and today we're going to talk about DIC, otherwise known as disseminated intravascular coagulation. So let's first start off to talk about what is DIC. DIC is a massive activation of your coagulation system, leading to multiple clot formations throughout the body, from macro to micro thrombi. At the same time, because your body is using up all these factors to create these clots, there are not enough clots to prevent your body from bleeding. So DIC is not only characterized by clot formation, but also by excessive bleeding. In patients who do have DIC, this is a red flag for a severe underlying disorder. DIC is never a primary diagnosis, but a secondary diagnosis. Before talking about the specifics of DIC, let's talk about coagulation. Coagulation is split up into primary hemostasis and secondary hemostasis. Primary hemostasis is when there's damage to tissue or blood vessels, and platelets stick to this damage, creating a primary clot. The clot is strengthened by secondary hemostasis, and this involves the intrinsic, the extrinsic, and the common pathway. We won't go into the specifics of each pathway, but I'll highlight some important points. First, the intrinsic pathway is monitored by PTT. Your extrinsic pathway is monitored by your PT lab. The common pathway is very important, and both the intrinsic and extrinsic feed into the common pathway. In the common pathway, prothrombin is converted to thrombin by activated factor 10A. Thrombin is an enzyme or a protease that cleaves fibrinogen in inactive form to fibrin. The role of fibrin is to attach to your primary clot and stabilize/strengthen that clot. In the conversion of fibrinogen to fibrin, unnecessary parts of the protein are cleaved off, and these are known as fibrinogen degradation products, which is something we can measure in your serum. Now that we know the basics of coagulation, let's look at the details of DIC. So first, we'll look at what are the causes of DIC. The causes of DIC are wide, and they include trauma, vascular aneurysm, sepsis and severe infection, severe liver failure, transplant rejection, placental abruption, preeclampsia, pancreatitis or other severe organ dysfunction, amniotic fluid embolism, ABO transfusion incompatibility, last but not least, malignancy. Note, all these disorders have systemic involvement, meaning they affect more than one organ. And that's probably the reason why they're associated with DIC. Now, how do you diagnose DIC? No single test diagnoses DIC. Really, you need to look at the entire clinical picture to lead you to a diagnosis of DIC. That includes the history, the physical, the labs. Next, we will look at labs that are commonly associated with DIC. And then we will take a look at a scoring system that can help aid us in our diagnosis. So first, let's take a look at thrombocytopenia. Thrombocytopenia means a low platelet count. The reason thrombocytopenia develops in DIC is that because of the activation of the clotting system, primary hemostasis is activated, and those clots start to stick everywhere they can to form these primary clots, and thus they're consumed. Note, thrombocytopenia is sensitive for DIC, but it's not specific because a lot of things can cause thrombocytopenia. Next, we'll look at fibrinogen degradation products and D-dimer. Fibrinogen degradation products are a result of the clotting system activating and causing the cleavage of fibrinogen to fibrin, creating FDPs, or fibrinogen degradation products. The reason we measure fibrinogen degradation products in DIC is that if the body is activating the clotting system at a very rapid rate, fibrinogen is becoming converted to fibrin very quickly, producing a lot of fibrinogen degradation products. So if the FDPs are high, we could infer that the clotting system is undergoing a massive activation. Now, fibrinogen degradation products are hepatically and renally metabolized, that means through the liver and through the kidneys. Because of this, if the patient has liver or kidney dysfunction, the fibrinogen degradation products may be falsely elevated. So that's something to keep in mind when interpreting this test during a patient who you think has DIC. Now we will look at the coagulation labs that we commonly get on patients. So PT and PTT. PTT measures the intrinsic pathway, and PT measures your extrinsic pathway. In about 50 to 60% of patients who have DIC, you will have a prolonged PT and PTT. Thus, you can actually use the PT and PTT to monitor DIC patients because they measure the pathways that involve the factors that are consumed in DIC. Another lab we commonly get is fibrinogen. Fibrinogen is classically used to diagnose and monitor DIC. However, you must realize fibrinogen in most cases may not be very helpful. And the reason why is fibrinogen has a very low sensitivity for the diagnosis of DIC at about 28%. Why is it so insensitive? Well, fibrinogen is an acute phase reactant, meaning when the body is stressed or sick, the body will produce fibrinogen. So the fibrinogen level may be falsely normal, though the body is rapidly consuming fibrinogen. hypofibrinogenemia is rarely detected in DIC. Really, it's only seen in the most severe cases. Let's talk about schistocytes, which are fragmented RBCs. Fragmented RBCs or schistocytes are reported in patients with DIC, but usually they are only about 10% at the most of red blood cells. Sometimes they can be more. It's not a sensitive or specific find to DIC because schistocytes are associated with many other disorders, including mechanical heart valves, vasculitides. So really, when you see schistocytes, consider other things that could be causing it, such as thrombotic thrombocytopenia purpura or other microangiopathies. Now, let's talk about antithrombin and protein C. Antithrombin and protein C are involved in the coagulation cascade and are often reduced in DIC. Though they do not diagnose DIC, they have been shown to have a prognostic significance. The scoring system we use in DIC is part of the International Society for Thrombosis and Hemostasis DIC scoring system. It's a fairly simple system. It's a 5-step diagnostic algorithm. The prerequisite is that the patient must have an underlying disorder known to be associated with DIC. It has 91% sensitivity and 97% specificity, making the scoring system very good in diagnosing patients who have DIC. So let's go over the system for DIC. So first off, you want to know, does this patient have an underlying disorder known to be associated with overt DIC? If the answer is a resounding no, then you cannot use the scoring system. However, if the patient does have an underlying disorder that's associated with DIC, you need to obtain coagulation tests. So your PT, platelet count, fibrinogen, and then a fibrin-related marker such as FDPs or D-dimer. So now we have to understand how to interpret the labs that we obtained. So we use a scoring system based on these labs. So for your PT, if your PT is less than 3 seconds, you get 0 points. Greater than 3 but less than 6 seconds, you get 1 point. And then greater than or equal to 6 seconds, you get 2 points. Now let's move to the platelet count. So for patients who have a platelet of greater than 100,000, you get 0 points. For patients who have platelets between 50 to less than or equal to 100,000, you get 1 point. And less than 50,000, you get 2 points. Next, we'll talk about fibrinogen levels. So for a fibrinogen level greater than 1 gram per liter, you get 0. And for a level less than 1 gram per liter, you get 1 point. Now let's move on to fibrin markers, so D-dimer or FDPs. If there's no increase, you get 0 points. If there's a moderate increase, you get 2 points, and a strong increase, you get 3 points. Now let's calculate the score. If you get a score that's greater than or equal to 5, that's compatible with overt DIC. For patients less than 5, this is suggestive of a non-overt DIC. So greater than or equal to 5, you have a definite diagnosis. If you have greater than or equal to 5, you need to calculate the score every day to monitor the patient and how they're doing with the DIC, whether or not they're improving or they're getting worse. But less than 5, we have a high clinical suspicion. Recalculate in 1 to 2 days and see where the score has trended. All right, we've gone over diagnosis. Let's talk about treatment for DIC. So for treatment, you always want to treat the underlying disorder for DIC because DIC is a secondary diagnosis. But if the patient is actively bleeding or needs an invasive procedure and the platelets are less than 50,000, I would go ahead and transfuse them with platelets. Now, in non-bleeding patients, our general goal is greater than 10,000 platelets, just because less than 10,000, your risk of spontaneous bleeding is so high. Now, for patients with severe hypofibrinogenemia, like less than 1 gram per liter, even though they had gotten FFP, then at that point, you can consider cryoprecipitate. But realize there's no data to suggest that this improves outcomes in DIC patients. Because DIC involves the creation of clots, there's always been this question whether heparin should be used in DIC. Now, heparin does inhibit the activation of the coagulation part of DIC, but realize there's no randomized trial that's demonstrated heparin use in patients with DIC had improved outcomes. So generally, we stick with the rule that if a patient is critically ill, they have suspected DIC, but there's absolutely no evidence or risk of bleeding at that point, then you can consider prophylaxis with heparin or low molecular weight heparin at prophylactic dosages to prevent clot formation. But this is really the minority of patients you'd probably be using this in. All right, we've gone over, we discussed what causes DIC, the diagnosis, and the treatment of DIC. If you like this video, give it a like. If you have any comments or any ideas for future videos, please comment down below. And definitely subscribe to iMedical School. It's Dr. K Medical School. And I'll see you next time.
Other thromboembolic disorders, Virchow triad, okay? Virchow triad postulates the presence of 3 factors that predispose a person to develop vascular thrombosis. They include hypercoagulability of the blood, alteration of blood flow in the vessels, and vessel wall injury and endothelial damage, okay? Hereditary thrombophilias, most of which are autosomal dominants, because they're going to involve structural proteins, increase the risk of thrombosis. More than 100 different known mutations exist and have been characterized. Acquired hypocoagulability include deficiencies in proteins S, C, and 3, and can also be characterized as antiphospholipid syndrome. So what are these? They're either acquired or inherited. Actual thrombus occurs due to the interplay of both genetic and environmental factors and follows a multiple hit hypothesis, explaining the inter-individual differences observed in patients with inherited mutation. Genetic factors can now be identified in up to 30% of the patients with VTE and are mainly attributable to factor 5, okay? Leiden and prothrombin G2021A mutations. These 2 thrombophilias implicate a weak thrombotic risk. Other inherited thrombophilias are rare, such as antithrombin 3, protein C, and protein S deficiency, which are about 1% of the general population, but they pose a higher risk for thrombosis. Acquired factors also influence coagulation cascades and include surgery, pregnancy, hormone replacement therapy, contraception, malignancy, inflammation, infection, and heparin-induced thrombocytopenia. Remember that activated protein C is the proteolytic component of the complex, and protein S serves as the activated protein C binding protein that's critical for the assembly of the anticoagulant complex on cell surfaces. The anticoagulant activity is expressed through the selective inactivation of factors 5A and 8A, okay? All right, let's take a little break. I'm gonna pop open all the quizzes that you've got attempts remaining for.